and let's get started.
We turn off the microphone so I don't hear myself over and over. Thank you.
Okay.
Okay, starting from the beginning, but right?
Yes, starting from the beginning, please.
All right, everybody. Thank you very much for the invitation to share this information with you. We're going to talk about the developing a screening and treatment program for critical congenital heart disease in Ivory Coast and the economic impact. I have no disclosures, and all the information that you will hear today is available on this article published on JAMA Open. So it's free of charge for anybody who wants to download the article and understand how the calculations and the numbers are performed. Before we discuss the cost of a program, we should know what we're losing by not having a program. So for every child with critical congenital heart disease that is lost, that means a average of 39.9 years of life expectancy loss, an average of $94,000 in personal income lost over the years that child was going to live in Ivory Coast, and 3.5 years of schooling lost. As you know, I don't need to explain to you, critical congenital heart disease represents about 20% of all the children born with congenital heart disease, and unless a procedure or a surgery is performed in the first 30 days of life, the life of that child will be lost. How many of such patients do you have in Ivory Coast? Well, let's calculate that there should be about 938,000 live births a year. And with the known incidence of congenital heart disease, about 7,500 of those patients should be born with congenital heart disease. Of those, about 20%, 1,500 new patients will die every year within 30 days of birth unless surgery or a procedure is performed. Unfortunately, physical exam detects only 34% of all critical congenital heart disease. So the vast majority, in the best case scenario, about 1,000 patients will die without even being diagnosed as having congenital heart disease. Unfortunately, we cannot do an echocardiogram to every child born in a country. That will be not very cost efficient. So the alternative is to do pulse oximetry. If you see this study is about the meta-analysis of 13 studies on pulse oximetry, and you put it all together as the screening of 230,000 newborns, and shows that the overall sensitivity of pulse oximetry is about 76, 77%, but the overall specificity is 99.9%. Meaning that if you have congenital heart disease, it will be catch in 99.9% of the cases. And if you don't, you're going to be a false positive in about 24, 25% of the cases. And that sensitivity, which is not perfect, improves after the first 24 hours after birth. In conclusion, pulse oximetry is a highly specific test with moderate sensitivity, but meets the criteria for being a screening test. In fact, the conclusion of this paper by Richmond and about 20 years ago already showed that newborn babies with important cardiac malformations are often asymptomatic initially, and the yield from clinical examination is poor. Therefore, measuring postductal saturation routinely in newborn babies before discharge home is an easy, safe, and actually not that expensive way to prevent these children from dying. and in such a way that the Secretary of Human and Health and Human Services in the United States about 20 years ago recommended that every newborn is checked with pulse oximetry upon birth and 24 hours later. So what will it cost to implement such a program in a country like Ivory Coast? And this can be applied to any country in Sub-Saharan Africa lacking this program. The numbers can be exchanged, but the result at the end you will see is the same on cost effectiveness. You can implement the program and catch all the patients, involve all the patients. Very difficult in Sub-Saharan Africa. Unfortunately, not all the deliveries are performed by skilled nurses or physicians. Therefore, programs like this had to be at the beginning implemented in big centers and big cities. So if you take the 10 largest cities in Ivory Coast, starting with the capital, you will see that the number of births at the 33.5 per thousand population ratio are about 269 of those original 900,000 that we mentioned. So the expected congenital heart disease, for instance, in Abidjan is about 1,200 patients and so on and so forth. And of those, the critical congenital heart disease is about 20%. So we're talking in the biggest 10 cities of the country, discovering, diagnosing 432 patients upon implementation. So when we talk about the cost, there's a number of assumptions we do in public health. We assume that you need one pulse oximeter for every 1,000 births. All births, you have to test all 269,000 to find those 400 cases. And a pulse oximeter of hospital quality is about 600 each, 600 American dollars, current dollars. The pulse oximetry that we can buy, at least here in the pharmacies, and they were so popular during the COVID epidemic, are very limited sometimes, and they have a lifespan of between 2,000 and 8,000 measurements, and after that, completely unreliable. So it has to be a hospital level oximeter. So we would need to buy, in order to cover all 10 cities and using one pulse oximetry every 1,000 patients, we need to buy a total of 267 pulse oximeters. And that will imply a total cost, as you see on the last column to the right, of $160,000 just to have the device. In order to do a good economic assessment, we also need to calculate for other things. As silly as they may sound, we need to count the cost in batteries that we need to have, the cost in salaries, and in time. And the time has been calculated at 5 minutes screening. So therefore, you can do 30 screenings in an hour. Batteries are $5 for 100 hours of battery, and the salaries were calculated at $3 an hour. So when it comes to batteries, if you have you spend $5 every 100 hours, and you need 8,900 hours to do all the screening, the cost in batteries for the whole program for 1 year will be $445. The same calculation at $3 an hour for salaries will yield a cost in salaries of over $26,000 a year. So when you put all the program together over 5 years, you have a capital cost on the first year of investment and monitors, $160,000. On the second row, you can see repairs, broken cable, lost sensors. You have to calculate about 20% cost every year to repair, fix, or buy things that get lost. And that 20% implies $32,000 a year in order to keep the program going without problems, $445 for batteries, and the salaries, $26,000 a year. And at the bottom, we have, of course, the first year is the most expensive because it's the capital investment, plus the everyday cost. But when you have this total cost is $424,000 for the entire project for 5 years, which seems to be a big amount of money for, especially for Africa. But here's the reality. The new patients detected in those 5 years with critical congenital heart disease, these are patients who are going to die unless something is done, and you cannot do anything unless you detect them. In 5 years, you will detect 2,165 patients. Let's assume that 90% survive surgery using a very high mortality rate of 10, which eventually should be much lower. Therefore, the cost per surviving patient, 423,000 divided at 1,948 is $217 per surviving patient. And therefore, since we knew that the DALYs, the disability adjusted life years averted for patient, were 39.9, the cost effectiveness is this intervention is $217 divided 39.9, which means $5 for DALY averted. For those of you who need a refreshment on what the DALY is, let's assume on the left side of the dial is birth, and on the right side is death, as it should happen. Assume any normal country, 60, 70 years that you should live a normal life. And every part of that diagram that is either pink or orange means years lived in disability, or as you can see, a dotted line showing death, those are years of life lost. So if you add every day that the patient is in the hospital and cannot work or go to school, plus all the years that that patient lives in disability because of pulmonary hypertension, because of inability to move from their house or the hospital, and then the early death, if you combine all that, that's a DALY. And we know that doing heart surgery in children prevents almost 40 DALYs, 40 years of life lost or lived in less than adequate conditions. So we're paying $5 in a program of detection for every year lived at full potential. So let's move on now to creating a surgical treatment program. And this, again, this data is available from our studies that had been published last year in a similar country. And when we do our calculations, I just want to clarify, what we are assuming is as if there was no program. So the numbers are adjustable according to what is available. We know that you have things going on, and it's not going to be entirely the same. So let's say that we wanted to start a new program from scratch in Ivory Coast over a five-year period, the same as the detection program. The capital cost for the first year, and the capital cost includes the pump, the heater cooler, monitors for the ICU, lab machine, X-ray machine. The capital cost for the first year will be about $665,000, providing that things are not, if you have to buy them. If things are donated, you can have a lower cost, the same as every equipment that is already available. Disposables and medications. It's very hard to go below $313,000. That implies, as you see on the fourth row, we are estimating 100 patients operated a year with at least with our foundation. That's what we try to accomplish. And that will bring the cost per patient about $3,000 to $4,000 in disposables and medication. And it's very hard to go below that number. When we travel to different countries, the cost of traveling, hotel, meals, and most importantly, transportation of every equipment or disposables, if we have to bring the disposables ourselves, is pretty significant, about $430,000 a year. We operate 100 patients, and this is a program based on 6 trips a year of 2 weeks each, operating 100 patients total during those 6 trips. So each trip is about 16 patients. We normally travel with teams between 12 and 18 people, depending on the local resources, as we move into a country and help develop the procedures and train the human resources, which are the most important. We normally decrease the number of members of the team as the local resources keep growing. So this is not calculated like this. This is calculated at a steady pace. So the total will be very expensive on the first year, $1,400,000, and going to half that on the subsequent years for a total of $4.3 million for a 5-year program to develop a critical congenital heart disease surgical program. And it's a big number, a huge number, but in those 5 years, you can operate 500 patients. Let's assume, again, being very pessimistic, a 10% mortality, should be much lower than that. So 450 will survive. The cost per surviving patient will be $9,700 per surviving patient. And the DALYs, as we discussed before, the years averted per patient, years that were lost and now are going to be lived in full, are 39.9, bringing the cost effectiveness to $244 per DALY advert. So just to understand what we consider, what is considered, not we, United Nations and international, any public health association considers cost effective. Anything that is less than 3 times the gross national income per capita of any country, any medical intervention, less than 3 times that is cost effective. And when it's much lower than that, it's very or highly cost effective. To give you an idea, Ivory Coast gross national income per capita is about $2,500, $2,600 a year. Times 3, it will be $7,000 or $8,000. And we're talking about 244 per DALY averted. So this is a very highly cost-effective intervention. To put in perspective, these 2 programs, the detection program, which is on the top, and the development of a surgical treatment program, which is on the bottom, there is lots of studies about the cost effectiveness of surgical interventions in Sub-Saharan Africa. The reason is because surgery in general is a neglected component in the development of the continent. Surgery, anesthesia, and OBGYN are very neglected. So all of us who are publishing in this area have done lots of studies about cost effectiveness. And this is how a surgical program for congenital heart disease compare to the rest of the surgical programs in Sub-Saharan Africa. The detection program is $5 per patient saved. Is nothing per year of that patient saved. Compared to an amputation, elective hernia repair, emergency hernia repair, and then the most expensive, which is the surgical prone, is barely above the cost of a fracture dislocation fixation. So it's very hard for any political decision maker to say, no, we shouldn't do cardiac surgery because it's too expensive. All you have to do is show them the numbers, and they will have a hard time arguing on the contrary. I just want to close with a quote from a very famous man. When John Kennedy in 1960 went to the American public and said, in the next 10 years, we're going to put a team together and we're going to go to the moon. And he said, not because it's easy, but because it's difficult. And I know how difficult things are in Africa. And I know that sometimes doing pediatric heart surgery sounds like going to the moon. It's not. 9 years later, the man went to the moon. And I'm sure that within 10 years, we should have lots of programs taking care of children in Africa. Thank you very much. I'm open to any questions.
Professor Cardarelli.
I can't hear you.